So welcome to HiNZ 2017, and we're talking with Tim Blake from Australia. And Tim gave an address yesterday to the conference, and his story is fascinating about the patient journey. Tim, welcome.
Thank you very much.
Would you mind telling us about that story?
Sure. Look, I came over from Sydney to tell the story of my experience as a carer to my wife through the journey of her hyperemesis gravidarum, or severe nausea and vomiting during pregnancy. My beautiful wife Lucy was about 10 years ago now, came down with severe nausea and vomiting. We didn't know what it was at the time. It was very confusing for us. It was a bit scary. And suddenly at 5 weeks of pregnancy, we found that she was so sick that she couldn't work anymore. And it really turned our lives upside down, and over the course of the next 40 weeks of pregnancy, she was hospitalised 15 times for up to a week at a time. When she was really acutely sick, she'd be vomiting 20, 30, 40 times a day. And I told the story of our experience through the health system, how there was oftentimes great care, and other times there were great holes in that care, and sometimes some lacking compassion. Look, we're grateful for the experience we had, and I think the condition now has some more awareness with the Duchess of Cambridge, obviously being a high-profile sufferer.
Is it a similar condition that she's had?
She has a slightly milder form than my wife does, but all nausea is actually debilitating. Some people say it's worse than pain because it just destroys your ability to think and concentrate and ruins your quality of life. Lesser known is the fact that the author Charlotte Bronte is thought to have died of hyperemesis in 1855, and my wife would have died without modern medicine too. Yeah.
So what do you think what was the result, and how were you able to translate that journey? Because telling it from a patient's perspective is so important.
Yeah, look, lessons. I think, as I said to you before, my day job is working in digital healthcare, and I've had experience as an executive in health systems, but telling stories is such a powerful way to help people understand experience, and it sinks in, I think, much more deeply than standing there and presenting some PowerPoint slides. So with my wife's full blessing, I was prepared to make myself vulnerable and tell that story, and there's some emotion that comes with that, as you might imagine. Obviously the end result is two beautiful children, Oliver, who's 9, and Jemima, who's 7, who are both very healthy. But there were some observations through that journey that I wanted to share because I think they're meaningful. I talked a bit about how healthcare is so much more than the appointment. For a patient, 99% of healthcare is outside of the appointment. And I talked about how online communities encouraged us and supported us, provided us with the opportunity to tell our story, to listen to other people's stories, and to experience compassion and care and advice. It wasn't about seeking a diagnosis from Dr. Google, far from it. My wife Lucy already had a clinical diagnosis, but it was about having a group of people who encouraged and supported. And that was probably the most important component of healthcare. And we consider that to be part of healthcare too, even though a lot of health professionals might not. So I was encouraging them to think in that way.
So that's part of the aspect of the patient engagement and wanting to engage. So between the first time that your wife suffered it and the second, were there lessons learned from the first time from the system or from how she handled it that made it easier, or was it?
So the experience in terms of the models of care and the care that we received was almost identical. Look, you know that you're a frequent flyer in hospital when an obstetrician says to you, "I don't know you, but I have heard of you." And my wife did experience that. But the models of care were the same, so up to 20 weeks. And I'm not sure if this has changed, I don't think it has, and remember this is in Sydney, Australia. Up to 20 weeks we had to go to emergency, where we were treated. My wife was treated very much like a transaction, a lady with nausea, and they tried to patch her up and get her out as quickly as possible, and that's their job. Beyond 20 weeks we were allowed to go straight to maternity, and we kind of heaved a sigh of relief when that was possible. What changed was, I think, in us, we learned a lot. We learned what language to use to trigger an admission, which is as I said yesterday, is very, on one hand it's comforting, on the other hand it's very dangerous that articulate advocacy can get a better outcome for patients, because I have a great compassion for all women who experience this, and those who don't have the ability to use the right words or speak in the right way to get the compassionate care that they want shouldn't be getting different outcomes. So yes, things changed, but I think it was more about what we learned, and the support that we got from the community was much greater the second time round because we knew what to expect, to the point where, and again I joked about this yesterday, I had 2 books. One was a book of stories of other women who had been through it, it's always encouraging to hear stories of people who got through it and survived. And one was a kid's book with possibly the worst title ever, called Mama Has Hyperemesis Gravidarum But Only for a While, told using rabbits. And it's one of the best read books on our shelf that has retired. But it's just nice to have little things like that to work through, because we had a son and he didn't understand what was happening to his mum. And we were greatly aided in that by my sister, who came over from the UK to live with us for 9 months to support us through that second pregnancy.
So, because a number of the other speakers yesterday as well that I was able to sit in on, there were discussions about the stories, and how important stories are. The aspect of empathy that often our professionals don't seem to have the time for because they're process oriented, and that whole aspect of the patient journey, which can be a cliche if it isn't fully interpreted, but it sounds like you've had that personal experience. So how can you take that, or how are you taking that and translate that into some of your work in the healthcare field or the digital field?
Firstly, just to make a comment about that, obviously it's not universally true that doctors, that health providers don't have compassion. Many, even most, do. I think the challenge is that the system doesn't allow them to express that. The system doesn't have compassion. The system doesn't have empathy. Many of the individuals do, and we had some wonderful caring people, but the system worked against us. I think in terms of how I translate that, I think the more astute would have noticed on the first page of my slides a little tick mark saying patients included. I'm part of a movement of patients who believe that every medical conference should include patients, and is allowed that tick mark when they do. I made some very strong comments about co-design, which is a common and growing movement within healthcare that we want to share and design with patients. But I'm wary of that because we have to be careful that we're not expressing our paternalism in a different way. If it's to be true co-design with patients, we need to let patients help formulate the problem, not just the solution. So if the system itself determines what the problem is, provides a number of solutions and lets patients vote for one, that's not really co-design. True co-design is saying to patients, what do you think the problem is here? And I made the bold statement that if co-design doesn't have the ability to change the timeline of a project or the funding of a project, then it's not really co-design. So for me, taking some of those thoughts and principles into the way that I do my consulting work is absolutely key, along with the empathy of being a patient. We all have a patient or a carer story. We all have one. And appealing to that, I think, often reminds people why they're in healthcare, because most people join this profession because they care. And they
care, absolutely. It's interesting you mentioned about making sure patients are event, but when we look at an event like we're here now, 800 plus people, and out of the 800, there's probably 800 patients. And I think we all, because we're in the professional side of it, either in the IT side or the clinical side or whatever, we tend to talk about that and then patients as being different people. And so maybe in hearing what you're saying is maybe we need to do is say, well, put our patient's hat on, perhaps more often, and we can wear both hats perhaps more effectively in a meeting.
There are, out of all the sessions here, there are 2 or 3 patient sessions. I'd love to see that proportion grow. That doesn't mean we have to bring in people who know nothing about the health system. You know, people like myself who work professionally in the health system, but just say, today I'm going to talk just as a patient.
As a patient.
Because I think a lot of us spend a lot of time thinking we know what the problem is and how to solve it, and reminding ourselves that we don't always, that we need some diversity in our requirements gathering, and that means talking to people we wouldn't normally talk to. Yeah.
Those are some really good ideas, Tim. Thank you so much, and welcome again.
Thank you.
Thank you.